groups. And so our special focus on sex workers today aims to kind of improve our knowledge and understanding, with the hope that we can take some of that learning into our organisational policies and practice. We're really keen to think about how we might be able to come together as a region and champion this work further, and hopefully we'll get some of that discussion throughout today and at the end of our presentations. But we're delighted to have some fantastic speakers today with real expertise and experience in this field, and I will welcome Lucy first, who's Professor in Public Health Epidemiology at the London School of Hygiene and Tropical Medicine, who's been working with sex workers in research for almost 2 decades, and her work focuses on understanding how social and health policies affect the health and safety of sex workers and other marginalised populations, both in the UK and internationally. So a really warm welcome, Lucy, and I'll hand over to you now.
Great, thank you very much. Thanks very much for having me. Right, I will share some slides. Can you see that?
Yes, clearly.
Yes, great. Okay, thanks very much. Well, thank you for that introduction. So my presentation today is going to draw on findings from the East London project, for which I'd like to thank my collaborators and colleagues for their contribution to the work, but also in particular to acknowledge Pippa Grenfell and Jocelyn Elms, who led much of the analysis I'm going to present. And there's a list of acknowledgements at the end of all the people responsible for the work. During my presentation, I'm going to present some examples of health inequalities that sex workers might experience in the UK. I'm then going to talk about how different social, environmental, legal, political, or economic issues shape sex workers' ability to mitigate risk and create inequalities. So I'm going to refer to these factors as structural or social determinants of health and use these 2 words interchangeably. But broadly, structural or social factors refer to factors that are not dependent on the individual, but are shaped by external forces. When I talk about health, I'm going to follow the WHO's definition of health as a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. So I'm going to consider how structural factors affect physical and mental health, as well as experience of violence. I want to give you an example of how one particular structural factor, that's criminalisation, sex worker policy and its enforcement by police, how that affects sex workers' health. So for that, I'm going to present findings from a systematic review that we conducted, as well as findings from the East London project. I want to talk specifically also give an example about how inequalities are exacerbated by racial and ethnic identity. And then finally, I want to bring it together and discuss briefly the implications, what these implications are for practice, for public health policy, service delivery and research. So, as Emma mentioned, sex workers can face multiple complex and interdependent health risks. We know from data in the UK that sex workers experience high level of violence at work, report high levels of anxiety or depression, and there's often an overlap between injecting drug use and sex work that brings additional vulnerabilities. Data from sexual health clinics suggests that prevalence of chlamydia is up to 10% among female and 25% among male sex workers. Gonorrhea is reported to be 3% among female and 17% among male sex workers, and HIV 0.2% among female, but up to 20% among male sex workers. So this represents significant disparities in health. So female sex workers are 12 times more likely to get murdered than women their age not working in sex work, and have between 1 to 3 times higher prevalence of chlamydia and gonorrhea than other women attending health STI clinics. There are also significant disparities within sex worker populations, with risk varying according to gender identity, working environment, and the local epidemiology of STIs and HIV. So we see higher prevalence of HIV among sex workers in countries where there's generalized HIV epidemics. We can see from our UK data the effect of gender on prevalence of chlamydia, gonorrhea, and HIV is much higher among men than women. We don't have comparable data on HIV prevalence among transgender sex workers from the UK, but a survey in Amsterdam conducted by Maaike van Veen and colleagues suggested it was up to 18%. We also know that location of sex work is integral to shaping risk, with street-based sex workers at greater risk of violence, STI, HIV, and poor mental health compared to their counterparts working off-street. And I'm going to present some further data to demonstrate this. So the extent of health and safety and inequalities experienced by sex workers is variable and shaped by individual, interpersonal, work environment and community factors, as well as broader aspects of the legal, economic and social environment. So Kate Shannon and colleagues in 2014 published this Structural Determinants of Health framework for researching and responding to HIV among female sex workers. This framework was adapted from the risk environment concept that was developed to understand drug-related harms and adapted to HIV and violence experienced by sex workers. It's in line with broader efforts to address social structural determinants of health, including work by Michael Marmot and colleagues, and of course, building on social models of health developed by Dahlgren and Whitehead, as I'm sure you're familiar with as public health specialists. But what this framework did was drawing on an extensive review of social science and epidemiological literature. It identified 3 levels of influence over sex workers' risk of HIV. The first was macrostructural, which referred to social and health policies, law, migration, and stigma. Then the second level was how sex work was organised, including the extent of community empowerment, belonging to or working in a collective, and the organisational structure of the industry. And then the third level was work environment factors, and this included venue policies such as having CCTV cameras to increase safety, as well as policing practice, access to condoms, HIV testing and treatment. It also highlighted the importance of interpersonal and individual factors to shaping HIV risk. So this framework has limitations in our understanding around experience of HIV risk among sex workers. It's quite reductive. It can't really be applied to specific contexts without understanding that context better, but it's a useful guide. It was limited also in its focus only on cis women, but that partly reflects less research conducted with trans, non-binary sex workers and cis men. Also, some of these structural factors are poorly characterised in research, including stigma. But it is useful in that it encourages us to move beyond thinking about linear approaches to understanding risk of HIV among sex workers. It helps us think about multiple pathways and feedback loops. The research focused on HIV. That doesn't to say that other health needs are lesser important, but this more reflects the scope of research conducted among sex workers, which has tended to focus on sexual health. But I want to show just briefly how this framework's been, the references. But moving on, I want to show how this framework has been applied in relation to the global evidence on sex workers' experience of violence. In 2014, Kathleen Deering and colleagues published a systematic review of epidemiological studies reporting on violence towards sex workers. They looked at measures of violence by any actor, including police, clients, partners, pimps, and others. and measured the independent effects of structural factors on violence. They identified a range of structural factors linked to violence. So the blue circles represent factors that increase risk of violence. And in addition to criminalisation, they found that measures of stigma, economic pressures, insecure housing, lack of access to harm reduction, and having been forced or coerced into sex work were consistently linked to increased risk of violence. Sex worker organising and empowerment, on the other hand, as well as access to peer education and specialist sexual health clinics, were associated with lower risk of violence. Meanwhile, indicators of migration or mobility, gendered inequalities, power and work environment factors were sometimes associated with increased risk and sometimes decreased risk, depending on the study. So, moving on to think more about how criminalisation as one specific structural factor shapes risk of shapes health and safety of sex workers. There's a growing focus in public health research on how criminalisation does influence health of sex workers. And in 2018, colleagues and I conducted a systematic review to pull together this evidence. So the aim of the review was firstly to measure the effect of sex work laws and policing practices on sex workers' health, safety and access to services, as well as to understand the pathways through which these effects occurred. So we synthesised evidence from 86 studies, 46 quantitative and 46 qualitative, that spanned 33 countries. We conducted a meta-analysis of the epidemiological data and found that sex workers who'd faced repressive policing were 3 times more likely to experience violence by any perpetrator. They were twice as likely to have to be tested positive for HIV or sexually transmitted infections, and 1.5 times more likely to have sex without a condom. Also, fear of arrest and increased police presence was associated with avoiding health services, poorer mental health, and increased drug-related health risks. The qualitative synthesis showed how these pathways worked, and we identified 4 main pathways. Firstly, we found that repressive policing practices disrupted workspaces and safety strategies. So, for example, through being displaced to more isolated locations and forced to work on your own, hindering risk reduction opportunities and forcing rushed negotiations around condom use or prices or services. The second pathway showed how policing practices institutionalized violence and coercion and extortion. And this was either directly through violent policing or indirectly through failing to act on sex workers' reports of violence and restricting access to justice. Thirdly, we found that policing reinforced stigma and inequalities. Policing practices targeted the most marginalised, including those working on the street, those using drugs, and populations already marginalised on account of their race, drug use, or sexual or gender identity. And fourthly, we found that policing restricted access to care. Again, the displacement disrupted outreach services, or fears of police links to service discouraged people from accessing services. So we found these in countries where with different sex work policies, including where clients are criminalised, service access was not improved and violence was not reduced. In countries where sex work was decriminalised, such as New Zealand, sex workers reported that it was easier to refuse clients, insist on condoms, and had improved relationships with the police and some services. But there were limitations to this, with some migrants were still excluded from decriminalised models. In countries where there were regulatory models to sex work, such as in Guatemala, Mexico, Turkey, and Nevada in the US, these kind of regulatory models exacerbated disparities where there were safer conditions for some who were registered to work, but excluded the majority, including sex workers who were underage, again, migrants, and sometimes those who use drugs. So in this review, we conclude that decriminalisation is a vital first step to improving health and safety of sex workers, but it's not enough on its own. It requires a policy and cultural shift, improvements in criminal justice, increased access to housing, immigration, health, welfare, and changes to anti-discrimination laws and labour rights. But we summarise that criminalisation serves to normalise violence and reinforces qualities and injustices. So I want to go on and look at this in more detail, taking the example of a study we conducted in London called the East London Project. And this study came about in response to the review that has been used widely for advocacy, but also highlighted that there was a lack of context-specific data in the UK and Europe. So the aim of the East London Project was to evaluate how removing sex work-related police enforcement affects sex workers' experience of violence, physical, sexual and emotional health, and access to health and social care services in East London. And we focused on 3 boroughs, Hackney, Newham and Tower Hamlets. It was a mixed method study that used qualitative interviews, a cohort study, including a baseline and follow-up survey, and mathematical model, to evaluate what would be the effect if we removed police enforcement practices on sex workers' health and safety. So I'm going to present mostly findings from the cohort study, but also draw on some of the qualitative evidence. So the overall study used a participatory approach, by which I mean that sex workers or people working closely with sex workers were involved in all aspects of the study design, its implementation, interpretation, and dissemination. So we recruited sex workers of all genders and nationality who had exchanged sex in the last 3 months in one of our study boroughs and were 18 years or older. For the cohort study, we used probabilistic sampling and convenience sampling to recruit sex workers across different sectors, including streets, flats and saunas. Participants completed a questionnaire on tablets or online, and we asked about demographic characteristics, their experience of policing, violence. Also, we asked about mental health and physical health and offered voluntary testing for gonorrhea and chlamydia. So data collection was conducted between 2018 and 2019. So firstly, I want to just present some findings of the characteristics of our sample. So overall, we recruited 288 participants at baseline and followed up to 60% over time at follow-up. So this slide separates out our sample by those working on the street in the last 6 months, and then those working in off-street settings. So both street and indoor sex workers were predominantly cis female, white and UK born or UK national. 26% of our sample identified as a racial or ethnic minority, so including Black British, Asian British, or mixed or multiple ethnicities, or otherwise racially or ethnically minoritized, including traveller or Roma populations. And there was a greater representation of minority groups in street-based settings. Men made up 26% of the sample overall and predominantly worked in off-street settings. Sex workers who worked on the street were on average 9 years older and had been selling sex for 11 years longer than those working in off-street settings. So these next 2 slides summarise some of the life experiences and health indicators among women. Reports from women working on the street are represented in the purple bars, and those working in off-street settings are represented in the orange bars. So over a third of women working in street-based settings had been in prison and were currently sleeping rough or living in an unstable accommodation. That was defined as either a parent's or a friend's home, sheltered or homeless accommodation. Around half had ever been evicted from a property. And among those who'd had children, half had had children taken into care, and 25% reported that their highest level of education they had completed was primary school. So that's schooling up to 11 years. So all these measures of social exclusion were lower among women working in indoor settings. So this slide summarises the main health issues. Around 70% of women working in street-based settings had experienced sexual or physical violence from clients and reported being anxious or depressed. Over half had ever attempted suicide. Drug use was pervasive and mostly related to crack or heroin use. So we focused mostly on mental and physical health needs in these studies because this was much more pronounced than the sexual health ones. We found very low levels of HIV and STIs. Again, all these health harms were lower among sex workers working indoors, but still higher than in other populations. So just for context, in 2014, the Adult Psychiatric Morbidity Survey showed that 16% of adults reported anxiety or depression, whereas here we see 34% reporting depression and 42% reporting anxiety. So in our questionnaire, we asked about experiences of violence perpetrated by clients, intimate partners, police, and others. And different questions were asked in relation to specific perpetrators, but a subset of these questions were asked in relation to all perpetrators and are therefore comparable across sources of violence. So I'm going to just present some findings of these comparable indicators in order to demonstrate a full picture of violence experienced by sex workers across their lives. I'm going to focus on sex workers working on the street where the burden of violence is focused. And these are all experience of violence measured in the last 6 months, so recent experience of violence. So as you can see from this slide, sex workers working on the street experienced violence from all perpetrators, and that's so the first chart shows prevalence of any form of violence, so emotional, physical, or sexual violence in the last 6 months. Graph, that's any form of violence. So the different coloured bars show violence from the different perpetrators. Blue represents clients, red represents others, which was defined as strangers or residents, neighbours. Yellow is intimate partners, and black is police. So you can see that 70% of sex workers reported any type of violence from clients, and that's fairly equivalent to violence experienced from others, including residents, neighbours, drug dealers, or other members of the community. 40% reported experiencing some kind of violence from the police. This was mostly in the form of emotional violence, so defined as verbal abuse, intimidation, or being scared. The third chart shows physical violence. Clients were the most common perpetrator of physical violence, then others, then intimate partners, but 10% reported physical violence from the police. The final chart represents experience of rape. Rape was more common among clients than among among other perpetrators in isolation. But in combination, this was 22% and not significantly different from the levels of rape perpetrated by others and intimate partners. Overall, 7% reported experiencing sexual assault by the police as well. We analysed this data to see whether there was any association between recent arrest and experiencing violence from other perpetrators, after accounting for confounders or factors that might be linked to arrest and violence. And we found that women who had been arrested were almost 3 times as likely to experience violence from others compared to those who hadn't been arrested. We also found that women who'd experienced intimate partner violence had higher levels of violence from others than women who had not experienced intimate partner violence. So this slide summarises levels of enforcement experienced by street-based sex workers. And I want to just highlight that the recent National Police Chief Council guidelines, which were updated in 2019, emphasised that the police starting point should be to ensure that they do not treat sex workers as criminals simply for being sex workers, and you should be around protecting and recognising sex workers as a vulnerable population and protecting them. But this slide shows that the vast majority of police enforcement is focused on sex workers rather than clients. 33% of participants reported that their clients had been stopped or searched or detained or arrested while engaging with them. Whereas among sex workers, 49% had been arrested in the last 6 months, 78% had been displaced from their place of work, 36% had had items confiscated, including drugs, drug equipment, condoms, 41% had been cautioned. Overall, 87% had experienced some kind of law enforcement in the last 6 months. So just moving to the qualitative evidence now. Our qualitative study showed that street-based sex workers were much more dependent on sex worker health and social support services than those working in off-street settings. And this was backed up also by our cohort data. So we explored how enforcement and policing practice might hinder access to services through our qualitative study, interviewing sex workers, service providers and commissioners. And this is written up in a paper by my colleague Pippa Grenfell, and the reference is listed below. But what we found was that access to sex worker services and other services varied. With experience being very diverse, and sex workers often reporting discrimination and reporting that service access was conditional on them adhering to certain behavioural standards. There was a lack of flexibility in services. We found that there was a close link between enforcement approaches in the borough and public health commissioning or decommissioning or cuts to services. So long-standing, trusted harm reduction services that focused on sex workers' needs and addressed social determinants of health lost funding during the course of our study, in part because they didn't align with enforcement approaches that sought to end sex work and prioritise exiting of sex work. But the ultimate effect of this was it worsened unmet health needs, especially mental health. And the most marginalised workers were impacted most by the cut because they experienced worse health outcomes and are most dependent on services. So the second quote illustrated here just gives an example of how of the reasons why cuts to services came about, and to some extent this was also attributed to austerity measures. Newer services were commissioned as exiting programmes, but were not grounded in sex workers' needs and lives, as this third quote shows, with the sex worker reflecting on how a previous service had been out until 6 in the morning and providing hot drinks, whereas this newer service was offered reduced hours to outreach. And didn't seem to understand sex workers' need, and there were concerns that they would be reported to the police. This study was also conducted pre-COVID, and these issues have all been exacerbated due to increased austerity and increased cuts. So throughout the qualitative interviews, sex workers argued for a shift in resources away from criminal justice to social justice, and request for services that met their needs on their terms and were peer-led. So before ending, I just want to return to the analysis of the cohort data and just focus on the whole sample of sex workers, including men and women and trans sex workers, and working across different settings. So we conducted some additional analyses across this whole sample to explore the extent to which police enforcement practices differed by ethnic and racial identity. So just to remind you, 26% of the sample identified as Black, British, Asian British, or of multiple race. And overall, these ethnic and racial minorities were more represented in street-based settings. So among sex workers working on the street, 51% identified as a racial or as an ethnic minority. Among those working in off-street settings, this was only 30%. So as a consequence of this greater representation in street-based settings, they experience higher levels of social exclusion in terms of homelessness, more drug use, and more intensive police enforcement. So as you can see from this slide, sex workers identify as an ethnic minority, which is they're represented in the dark green bars, experience greater levels of enforcement than white identifying sex workers who are represented in the paler green bars. And this is across all measures of police enforcement practices. And this, as I said before, is in part due to their greater representation in street-based settings. However, after accounting for confounding effects of working sector, as well as drug use and time in sex work, they continue to experience disproportionate arrest, imprisonment, and police coercion. Okay, so to conclude, so in summary, we find that sex workers experience inequalities in housing, mental and physical health, and this is particularly stark for those working on the street. We found that police recent arrests in the last 6 months was linked to increased odds of emotional, physical, and sexual violence. And although these findings don't imply that enforcement causes these types of violence, and given that this is an observational study, when we take these findings together with evidence from qualitative interviews and from a growing body of international evidence, our findings support the value of stopping enforcement against sex workers. We found that there was disproportionate police enforcement, violence, arrest, imprisonment, and extortionate experienced by ethnic minorities. And this further supports the need to decriminalise sex work as a matter of racial justice, as well as one of broader health and social justice. It also highlights the need for reform to tackle institutional racism in policing, alongside efforts to tackle violence and discrimination against sex workers. So legislation and policies that are supposed to protect sex workers clearly don't. And this is reflected in the lack of trust in the police to adequately investigate crimes. We found that just 14% of our sample had reported violent crimes to the police. Violence prevention to date has tended to focus on violence from clients and intimate partners, yet we clearly see that violence from other perpetrators and police is comparable and there's a need to tackle currently overlooked sources of violence from other perpetrators, including from police themselves. Public health policies has historically focused on sex work rather than sex work as a consequence of social inequalities. So policies and services need to respond to these diverse health and social support needs of sex workers, including providing better access to housing, benefits, social services. So addressing the conditions in which sex work is conducted. In terms of research priorities, we conclude that there's a need for further evaluation of interventions to reduce violence from different perpetrators, as well as research to better understand how to reduce and prevent social exclusion and stigma. So that's all I wanted to say, other than to thank everyone who participated in the study and also my collaborators. And I realise I bombarded you with a lot of data, so happy to take any questions.
That's wonderful. Thanks, Lucy. We will pick up a couple of questions now, even though we're running over a little bit, because I know you've got to dash, Lucy, for lectures and things. So there is a couple of questions in the chat that we'll pick up, and then I've seen a few hands. So Terry's got a question around the actual numbers for on street and off street sex work on the slides that you've got to give a sense of scale and impact. I think they were in earlier slides, but I wonder if
I may have missed it, Emma. It's just obviously on the street is more vulnerable, but I was just interested to know what the numbers were for on and off street. Apologies if I missed that.
You mean how many people we recruited?
Yes.
Yeah.
So it was 100 sex workers working in street-based settings and 186 in off-street settings.
Oh, okay, good.
Yeah, that's
really helpful. Thank you.
No problem. And then a kind of related question from Noor about whether we've got an understanding, a rough understanding of the absolute figures for the UK in that context as well. Is that right, Noor? Have I read that
yes,
correctly?
correct. Yeah, thank you.
How many sex workers are working
kind of on street and off street? Do we have any sense of that UK wide?
Well, that's a $1 million question. I know. Well, there have been estimates conducted, but not recently. And actually, Raven might have more up-to-date data on this. But I think there was a report published in around 2005, estimated, I think, about 90,000 sex workers, and they do give estimates of proportions working across different settings, but I can't remember the figures at the moment. But
that's absolutely fine, Lucy.
I just want to
look that up.
Yeah.
Go on, Noor.
Yeah, so I just on the slide 2 where you show 40%, 60%, so there must be absolute numbers. I'm just wondering, maybe we can get from there.
Oh,
that's for the that's for the particular study.
Yeah,
Noor. Yeah,
okay.
they're on the slide, so we can share that.
Yes, the references are listed. So
Thank you.
yeah.
Let's introduce Kathy Roughton and Georgina Wilkinson. So Kathy Roughton is one of the programme managers in OHID in Yorkshire and Humber, and leads on inclusion health. She's championed this area for public health for many, many years, and she's joined by a colleague from the UK Health Security Agency, Georgina Wilkinson, who is one of the sexual health facilitators, one of 9 across England, and she covers the Yorkshire and Humber region. And I know we've got Kate, South East colleague, on the call. So their remit is to support stakeholders who commission and deliver sexual health, reproductive health and HIV services across the region, with a focus on improving public health outcomes and reducing health inequalities. So over to you guys.
Thank you for that introduction, and yeah, that was a powerful presentation from Raven, so it's going to be tricky to follow that, but we'll try. But a lot of the issues that Raven talked about, I suppose, is what we're trying to look at within our public health approach to sex work. So So that's kind of reassuring, I suppose. So we'll try and catch up on a bit of time because I know we're running a bit late. So next slide, please. So just to say, we decided to do some work around sex work across Yorkshire and the Humber in 2022, so about 18 months ago, and we did that for OHID and UKHSA, but also for our Association of Directors of Public Health, who were keen to look at sex work across our region. And the reason why we wanted to do it is because we wanted to better understand the health and wellbeing needs of sex workers, both indoor and those working on the street, and look at some recommendations to inform the approach to improving the health outcomes and reducing the inequalities that we know that sex workers face. So we established a steering group across the region, which I'll come in to talk more about shortly, and we're working collaboratively at the moment to develop our public health approach to sex work, which is what Georgina will talk about after me. Next slide, please. So our scoping objectives 18 months ago, because we knew very little, we wanted to identify where we had place-based sex work leads in Yorkshire and Humber, so within the local authority and the Integrated Care Board. We wanted to scope out any strategic planning and work streams around sex work regionally and at the ICS and place level. Wanted to understand and describe the services that were being offered to sex workers in the region and learn from different stakeholders about their role, looking at where there might be gaps and also examples of sort of good practice, and agreed the recommendations with stakeholders going forward. Next slide, please. So our project plan was this. It took 6 months. I won't go through it in detail, but we basically established a small working group. We did a review of the literature. We met with stakeholders. We did a survey with through the local authority public health teams to gather information about work that they were doing around inclusion health groups, which included sort of sex work. And then the final stage was around sort of analysing our the information we'd got and summarising the findings and recommendations. Next slide, please. So in scope was on-street sex work and indoor sex work, and not to say that other settings won't be explored more in time, but that was just the scope for this particular piece of work. So we had around about 30 meetings, and it was quite a brief scoping exercise just to get some initial understanding of what was happening in relation to sex work in our region. We met with lots of different stakeholders, including National Ugly Mugs, all our police forces, community safety, all our sex work projects, as well as other projects that focus on wider sexual exploitation. Next slide, please. Next one. So these are some of our key findings. One of the sort of key things was most of our understanding is from service providers rather than any formal data sources, which just don't exist. Health and wellbeing needs vary and can be based on the type of work, so on street versus off street, but that's not always the case. Definitely in terms of any sort of planning, commissioning and provision, the focus was predominantly on street female sex workers and far less on sort of protective factors and prevention much earlier on. And when we talk about prevention, we're not necessarily talking about prevention of sex work, but the harms associated with sex work. So we've got some really excellent frontline services, but they're usually focused in the urban centres. Funding and commissioning is really complex, very difficult for services to be able to provide support to sex workers, and certainly we found that some of our services had to prioritise just working with the women working on the street and stop looking at work that's happening indoors because of the way they were commissioned and the capacity and everything, which is a worry. So partnerships and collaborative working varied at place. There's some quite good operational sort of collaborations that are happening, but much less so at a strategic level, although there were some exceptions. Next slide, please. So our recommendations, the main one, which is what we're working on at the moment, and Georgina's going to speak about, is to develop a framework for a public health approach to sex work. So you might have seen other public health approaches to other topics. So there's one on modern slavery, for example, which Liz Such led, which we sort of based a lot of our framework on. So the developing the framework was around sort of exploring what the wider determinants mean for those involved in sex work, rather than just focusing on people who are just working as sex workers, but it's also around sort of identifying what the protective and risk factors are and taking sort of a life course approach, so addressing the needs earlier on. Next slide, please. And these are our other recommendations. So we were keen to be clear, you know, to have sort of definitions and scope that we all agreed to. Looking at our data intelligence, which is what we're starting to look at the moment. So look at more depth around available data sources to improve our understanding. So there are bits of data, but one of the sort of major gaps that we found is what's happening indoors, and what are the sort of health needs of people working indoors, what are the vulnerabilities, etc. So we're just trying to sort of progress some work around that at the moment. Looking at subgroups, so the sort of intersectionality comes in here as well. So looking at migrant sex workers that are working indoors, trans sex workers, identifying what some of our strategies and levers are. So knowing that people are really stretched at the moment. There's, you know, massive issues around capacity and funding. So looking at what some of the opportunities are already that we can utilise, rather than suggesting something, you know, sort of a specific work stream happening. Looking at training awareness, networking and sharing of practice. I was quite surprised that a lot of our sex worker projects, for example, there's no sort of network across the region for them to be able to get sort of peer support and network and you know, share sort of examples of practice and look at sort of common issues, etc. And then the other one was around leadership, so that was around developing this steering group to take the work forward. Next slide, please. So we've got our steering group. We convened that for the first time in March last year. We meet every 2 months. Membership is quite wide ranging. It's co-chaired by someone with lived experience and myself, and we do pay the lived experience leads for their contribution, and that's been a really important part of the work. Next slide, please. Where we've got to, so we've established lots of new relationships, which has resulted in some research being commissioned. The police leads for our force areas are now meeting regularly, which they weren't doing previously. We're raising awareness more broadly. We've got our public health approach document in draft. We're sourcing practice examples at the moment that relate to our public health approach. We're considering doing a face-to-face event, but certainly we'll be doing a webinar to launch the work. And Georgina and her colleague presented at the National UKHSA conference last year on this, and I'll pass over to George now. Thank you.
Great, thanks, Kathy. So yeah, so Shaheen and I, who's my equivalent colleague in the east of England, she's been doing similar work there in terms of scoping, and actually what we found was there's very kind of similar findings across regions. So, you know, you're starting this work here, you are likely to find similar things because there's no reason to think any different, I suppose. So like other people have already said today, you know, that the health and well-being needs vary between street and those working indoors. But the kind of really crucial thing is around the data and information. And actually, you know, the stats on sex workers, you know, are missing from routine data sets. So there's no point everybody going off looking for them, because they're not there. But actually, the most useful insights are from our kind of local sources of data, and that's where we need to kind of focus our time and effort. And just because it's not showing up in routine data doesn't mean that the issue isn't there in kind of each of your own local places. And in terms of kind of service provision, so that mainstream health provision doesn't often meet people's needs, but there are really good examples of frontline services, but it's that kind of ongoing issue of capacity, kind of continuing to source funding, etc., which means that the emphasis, being able to put time into kind of strategic collaboration and sharing good practice is kind of limited. Next slide, please. So kind of moving on, like Kathy said, what we've been focusing on in Yorkshire and Humber is developing a public health approach. So this is it's going to be like a web-based tool. We didn't want another lengthy Word document PDF, that's 20 million pages long. We wanted a kind of interactive tool. So next slide, please. So this is just how we've set it out. I'm not going to go through in detail all of this, but this is kind of how we're structuring it. Next slide, please. So we've got intro and background pages, but in sort of as briefer words as we possibly can. We will be very happy to share this with you once we've got it into that stage. Next slide. So we've tried to explain more generally what a public health approach is, and about kind of focusing on prevention at a population level, and proactive activity to address the causes of the causes. In the context of sex work, as Kathy has already said, prevention isn't about preventing sex work, it's about preventing the adverse consequences. And it is really about this kind of trying to shift the focus upstream, and about intervening early. Next slide. So this is what we've come up with our steering group. This is our framework. There are 6 different elements to it. So the 3 in the red are there. The blue, the one in the blue, the improving wider economic, social and legal conditions, is really important, and we wanted it in there, but at a regional and local level, we felt we had less ability to influence that. And then the improving health equity outcomes and inclusion, and the empowering sex workers and reducing stigma run throughout the other 4 elements. Next slide, please. So this just sets out in words what the elements are. Next slide, please. So in terms of a focus on empowering sex workers and reducing stigma, this is about increasing awareness and education amongst all stakeholders, and as we've already heard today, that reducing stigma and reframing people's perceptions is absolutely crucial in this space, and therefore it's kind of central to what we need to be doing. Next slide, please. As is improving health equity, and this is around that kind of advocating for health in all policies, and considering intersectionality throughout all of this. Next slide. So this is the one where we felt we absolutely needed to include this, but it's very kind of broad, and it's that kind of making changes at sort of national policy level, and how can we work with that at a local level. Next slide. So working in partnership, This is around kind of that real focus on collaboration at both strategic and operational level, and it's thinking as broadly as possible about all the key partners, and actually some of this is around engaging with partners who we might not normally engage with, you know, from a kind of health space, but it's really important to do that here. And that emphasis on kind of clear leadership and governance structures at both place and wider level, that's kind of really important to think about how you can do that and influence that. And the intelligence gathering, so you know, how can we work collectively in partnership so that we do develop that better understanding of the position, you know, and all the things around sort of data sharing and thinking about both qualitative and quantitative. So next slide, please. So this is about thinking about partnership service design. So recognising that within any service, you know, there are no hard to reach groups, only hard to reach services, that we need to think about providing information and support in a wide range of formats that don't stigmatise anybody. Really crucially, you know, is about involving people with lived experience, because actually, you know, who are we to say what was going to work and what isn't going to work? So we really need to spend time and energy getting that understanding. And I think the other kind of key thing is about this sort of regular review and evaluation of system working. That's kind of needs to be an ongoing process. Next slide. So person-centered service delivery, other people have talked about this today, but it's absolutely, you know, we need to be taking that person-centered approach and ensuring that there's good coordination between all services, so that you're taking that kind of holistic, personalized, kind of tailored approach, and that services are delivered in a trauma-informed way. Peer support, again, is really crucial in terms of supporting people to navigate through the kind of multitude of provision that we have. And that the kind of staff training and education for people working across a whole range of services. So this is not about sex workers specific services, but about, you know, all primary care, hospitals, sexual health, mental health, community services, and wider non-health services as well. Next slide, please. So we've developed an action plan tool so people can kind of self-assess, either, you know, individually as organisations, or more ideally within a local system. And if you just move on to the next slide, it's you know, we've got one for each of our 6 elements, and it's just kind of key things to consider, to think about, you know, are you doing this, and where have you got gaps and where have you got kind of good practice. Next slide. So we're still working on this at the moment, as I've said. We're really keen to include some practice examples from all our various partners and stakeholders, not around service delivery, but around how they are working to address each of those 6 elements. And then we will include some tools and resources. So that's very quick whiz through, and I will stop there. Thank you.
That's wonderful. Thank you both. Really, really great stuff. There are a couple of questions in the chat, but I'm mindful of time, so I am going to move on to Mel. But I don't know if you guys would mind, if you can answer the questions in the chat, and you're able to, that would be fab. Otherwise, we'll try and pick them up after Let me introduce Mel Potter, who is project manager for the Sex Workers Outreach Project in Brighton. The main aim of the project is to promote the health, safety and wellbeing of sex workers. And Mel has been working with sex workers for over 20 years in Brighton and Hove, and has been based within the HIV and sexual health as well as substance misuse treatment services. She's previously been involved in the Fulfilling Lives project in Hastings, supporting homeless women with compound needs. That might mean complex. Mel was awarded a Public Protection Award in 2022 for facilitating co-production in relation to facilitating dialogue between sex workers and Sussex Police in relation to experiences of policing and identified areas for improvement. So we're really grateful, Mel, that you could come and talk about your work in a bit more detail. So over to you, Mel. I think you might be on mute.
I came into this quite late into this meeting because of being in another meeting, so I wanted to apologise in advance if I duplicate any of the presentations by Lucy and Raven.
No problem at all.
But I'll try and focus more on our service delivery. So yeah, we've been supporting sex workers at the Oasis project, I think since kind of probably about 1999, 2000, just to give a bit of historical context. I think in the late 90s there'd been some research done at University of Sussex that showed that there was a need for support for sex workers who weren't accessing services, and a number of women were interviewed and had said they felt there was an additional need. So at the time we sort of tentatively started doing some work, and then we actually got funding in about 2001, and so we've managed to kind of continue with that work since that time, and it was initially under we've always been funded by public health, so it's been very much initially focused on access to healthcare and sexual health and HIV prevention, as well as kind of linking people in with sort of substance misuse and wider services. So in terms of what we offer as a service, we try and keep it fairly person-centred and work with where people are at. And so we offer things ranging from sort of like brief advice and information, and also crisis interventions as and when needed. So that might be reporting crime or someone suddenly becoming homeless. And then we offer sort of longer care plan support, particularly for those with kind of multiple and complex needs. And for the brief interventions and advice, we've always allowed people to access the service anonymously, so they're not forced to share personal information if they don't want that. Although we're based in Brighton and Hove, if people ring from other areas, we won't just send them away. We'll sort of help actively, where possible, facilitate their access to services in their area. Or if there aren't any appropriate services in their area, obviously we encourage sort of linking in with National Ugly Mugs as a national service, and then supporting people sort of around any kind of immediate needs there and then. Yeah, we also do sort of sexual health intervention, sexual health intervention, so that can include the sort of self-taken swabs and bloods for chlamydia, gonorrhea, syphilis and HIV. And we also, there's quite a lot of advocacy and outreach involved in the service, so we will support people who may otherwise struggle with access to clinics, and support them to attend through kind of meeting them, and also facilitating outreach from the sexual health team as well. We are so Oasis Project is a women's service, but we've always been trans and non-binary inclusive, and we also, I think one of the key components is we do acknowledge the very vast diversity of experience within the sex industry, which I'm sure has been sort of touched on earlier. Could do the next slide, please. Yeah, I just wanted to mention briefly with the Oasis Project, we are based within a women's substance misuse treatment service, but we don't insist that people have a substance misuse issue to access the sex worker project, and we don't promote ourselves as a substance misuse, that element of the service as a substance misuse service, because having spoken to sex workers, it meant that lots of people felt that they couldn't access the service. So it's open to anybody, whether or not they use drugs and whether or not they want access to drug and alcohol treatment. But we deliver those services sort of in either as part of the treatment service or alongside people's drug and alcohol treatment, and then we have a wide sort of variety of women that are not in need of drug and alcohol treatment on our caseload. And the next slide, please. I just wanted to touch on how we define sex work. So, yeah, I suppose in line with the World Health Organization. So, as the provision of sexual services for money or goods, and where though it's sort of defined as income generating, even if the person doesn't consider sex work as their occupation. And I suppose to add to that, we do take referrals, and very occasionally we have contact with people who it may be income generating for other people, but where they're not, that it's basically been modern slavery, and they've not been benefiting in any way at all. Can I, the next slide, please? Oops, sorry. Yeah, and just to focus on why we use the word sex worker. So we feel that sex worker, it was coined by sex workers themselves, and I know there are different thoughts about the use of the word sex worker, but we feel that the use of that is important because it's affords a sort of some level of self-agency, and it accounts for the diversity of experience of those in the sex industry, whether that's good or bad or exploitative or non-exploitative, and it also allows for sexual exploitation or coercion, modern slavery or rape or sexual abuse to be identified as such and separately defined, or defined alongside the term sex worker, rather than being something that's assumed about somebody. In terms of our clients that we see, so the sex work that's involved that they will do is really varied. So I just suppose wanted to emphasize that. So some people may be doing an in-person sort of full service, or sort of forms of penetrative sex, and there may be maybe through sex parties or escorting, seeing people at home or in a hotel where they're based. And we also have a number of service users where there's no direct sexual contact, and people who are maybe specialise in sort of BDSM and fetish and role play, and may have very little direct sexual contact with their clients. And people may see regular clients who they've known for sort of 10 years or so, or some people may regularly see strangers as clients. And we have a number of people who may be more opportunistic with their sex work, so just as and when they need money may approach somebody or have people that they'll see for some form of transaction. We, especially with our younger people that use the service. We find quite a common form of sex work is done through sugar dating, so maybe having just 2 or 3 individuals that they're kind of hooking up with to get a sort of a regular income, and sometimes the risks from that can be very different because it's not seen as professional boundaries and can be a lot more of an intimate relationship. And then we have a number of people who do sort of pay-per-view content or live cam work, or may also work in the adult film industry. And some people have experience across all of those throughout their career as a sex worker, or maybe at any one time. And in Sussex, I'd say we have no real visible street scene, which is why our focus is very much on indoor workers. And we do have some women on our caseload who've been long-term homeless, who may dabble in a bit of both, but we don't really have visible beats certainly in Brighton and Hove. And I think that having spoken to partners across other areas of Sussex, yeah, it's not sort of a really visible issue, but we do know that some of our service users do that. But certainly in Brighton and Hove, we have quite a high level of support for people in the homeless community and a number of other outreach services, which is why we tend to focus a lot of our resources within the capacity that we have with engaging with indoor workers. About when we first started, we had lots of contact with migrant workers sort of through massage parlours, and I suppose since the internet, now the bulk of our workers are online, and since COVID, then our contact with migrant workers really dropped off, and it just shortly prior to the COVID pandemic, it coincided with a couple of significant parlours in Brighton and Hove closing down, one due to police issues and one for other reasons. But that sort of has made it a lot more of a challenge in terms of our contact with migrant workers. It's slightly improving now, and we get referrals now from the police, and that's partly because people are a lot more hidden than previously, and it's much harder to access them. I should move on because I'm aware we're pushed for time, but I suppose it was just most of our clients, most of our service users get their clients from a range of online platforms and websites and the classified ads, and some might be on more interactive adult web platforms. And then with homeless women, quite a lot of the time they're approached when begging, or it's sort of just when they're in the street. Sorry, can I use the next slide, please? It seems to have jammed. Thank you. I just wanted to touch really on sort of like media and sort of wider society conceptions of sex workers. And I know when we ran a service, had a growth of service users where we had a meeting with sort of police, and so that they could give feedback back previously. One person had sort of said, you know, we feel like we're always seen as victims and criminals, and it can be kind of, you know, it's hard sort of like looking at, I suppose, the wider perception by society of sex workers, and how that impacts them. I thought I'd put those sort of like images and words up because it's worth kind of looking at what our service users are kind of carrying with them and what they're facing sort of on a day-to-day basis. Also, can I have the next slide, please? And I suppose highlighting that common feedback that we get from our service users is actually the stigma of being perceived as a victim, and because of the fact that that kind of, for them, it sort of means like a lack of agency, and also it means that when someone's being perceived as a victim, it means that decisions, including things like policies and legislation, are often made without any consultation and without sort of and it kind of like when it's sort of with an assumption that it's for their benefit, when maybe in fact it's not. Another impact that we frequently see and have seen over the years is exaggerated fear of infection, sort of, I suppose, from sex workers themselves and from sort of like the wider groups. People who've often felt that because of the stigma that they've felt and been made to feel like that they're at risk of carrying disease, that they felt unable to kind of wash clothes with their children's clothes, have been worried to hug their children, and it's always sort of like worth thinking about that when sort of addressing sexual health issues, I think, with anybody. So in terms of self-isolation, what we often find is that people say that they will often avoid new friendships, and often will self-isolate because they don't want to lie about the fact they're a sex worker, as well as it not wanting to share, and so that can also kind of just compound sort of social exclusion, and I'm sure it's been touched on earlier about the lack of access to things like banking for sex workers that can occur. Sorry, the next slide, please. I suppose just to give examples of like social exclusion, touching on a case that we've had fairly recently, where a variety of cases where we often get people who are excluded from banking. So it may be due to and they may be wanting to kind of register, pay tax, but obviously want to be able to open business accounts, and don't, if clients are paying by card, they maybe don't want to give their personal details, and there's a variety of other reasons why people are excluded. And they said the feedback they get from banks is that they've been told there's risk, it's too much risk of money laundering, but then they're left with giant wads of cash. But the result of that is often when things start to go wrong, it means that they're not able to access housing because maybe they're not able to produce bank statements. If they're homeless, they're not priority need. They may have no deposit or no guarantor, or for a variety of different reasons may not be entitled to benefits. And so all of this can kind of compound and mean that they're not entitled to, not seen as a priority need for housing. As a result, we get a lot of people that then stay off grid a very long time. So they may have no rent contract and only able to sublet or access hotel or Airbnb accommodation. So then they're often excluded from emergency accommodation because there's just no sign of them having access to health services or having any needs. And often what we find, it's only once there's quite a significant crisis that we've been able to actually get things like housing support. And I wanted to kind of touch on people with EU settled status, because what we are finding are people where there's been lack of evidence of continuous residency, because of maybe no bank account or concerns about what is on their bank account because it's undeclared income, that can lead to people having put off applying. And we've the AIR Centre have been great in supporting some particularly complex cases. But as a knock-on effect, it often means, again, no access to benefits, which I know with one service user, even throughout an entire pregnancy and early on with having had a baby, she was not able to, until her EU settled status came through, she was not able to access any benefits. She was in private rented accommodation that was unsafe, where she wasn't able to pay the rent, but so she's sort of ended up in a lot of debt. She couldn't get access to refuges because of housing benefits, and both adult social care and children's services were unable to provide actual income for her. And it also meant that the council were not able to provide emergency housing. And it changed once she got EU settled status, but I'm finding increasing numbers of people where they are in that situation. And the impact on mental health is huge, especially where there's maybe another issue going on and someone's in crisis, and then they're not able to access that. And it's quite, and it can be very difficult for all the staff, all the services that are involved with that person as well. Next slide, please. And I wanted to touch on the, I suppose, the intersection of the different areas for reasons why people are socially excluded, and the impact that that has on their sort of safety and their well-being, both in terms of, I suppose, determinants of health, sort of sexual health, the level of maybe sexual health risk and risks to their personal safety. Yeah, and so the stigma and fear of legal or social consequences is obviously a key factor. And exploitation and domestic abuse, all of those that we come across, like in turn, all those factors, the more that there are, the more that we find that people are unable, maybe less able to make choices about how they sex work, and how safely they sex work. And when they can leave, if they're not happy, and that obviously then has kind of ongoing effects in terms of sort of either both mental and physical health. And I wanted to, I suppose, one of the things that has come up with some of a couple of service users and people who sometimes come back from our service is sometimes there are long-term health effects, maybe many years after some people have left sex work. So sometimes that might be mental health related, but also I've had conversations recently about who've, with their peer groups, have had discussions about the need for a lot of sex workers experience kind of musculoskeletal disorders, or some people have them anyway, and then others may experience problems due to sort of, I suppose, repetitive actions sort of during sex work. And then there are other issues for some people, such as prolapses, and sort of long-term health effects that may be directly linked to sex work. And it's maybe something that an area that's quite hidden. And
Mel,
that people.
Mel, sorry to interrupt you, but just to remind you, we've got about 5 minutes left.
Okay, lovely, thank you.
Okay.
Can I have the next slide, please? Yeah, I suppose we take a harm minimisation approach with our service, as it does not make assumptions about the experience of sex work. And it does respect that many people don't have the desire to leave sex work, or that people may not be willing or able to exit sex work right at that moment, but encourages self-care and safe working. If the next slide, please. And I suppose just wanted to highlight how the kind of key principles around harm minimisation also match up pretty much exactly with the trauma-informed approaches to working with people. And the next slide, please. this is just feedback that we've had. It's over. Some of this is very historic, but I was delivering some training to some GPs a little while ago, and I thought I'd sort of bring these along. And then strangely enough, I can't find it to reference it, but I'd also recently seen a study in the Netherlands done with sex workers, and what was kind of interesting was it pretty much matched what we'd heard over the years from sex workers. But it was often things like sort of assumptions that particular health problems might be directly linked to work. And there was one where somebody's GP had sort of, I suppose, expressed kind of disapproval about anal sex, and they were told they probably had HIV when and they'd actually only ever had anal sex with their husband and never with their client. So it was that assumption that about kind of sexual behaviour. But I suppose what you might expect, that a lot of people don't want information shared with GPs and don't want it on their records, and they're worried about how that will carry with them getting treated differently, maybe over many years, and about often being seen as a problem, or that they're putting themselves at risk. Sorry, could I have next slide, please? And as a health service, that bringing in thinking about the burden of stigma, so that when somebody's coming into the health service, this is it's like these images that I'm showing here, obviously very, very old, but that's still from discussions with our service users, that kind of wider attitude around sex workers and being responsible for carrying disease often still sticks for a lot of people, and so even sort of going into any general services and talking about things like sexual health could be really difficult. We frequently get people talking about shame and guilt, and often, certainly in our wider substance misuse treatment services assessment, that's often how it's picked up on, that they're doing sex work. Could you put the next slide, please? I mean, in terms of positive feedback, the things that's not a surprise are just feeling listened to, and feeling that they weren't judged, understanding needs as trans women, and people being sort of, I suppose, respectful, and being supportive. The next slide, please. Sorry. Yeah, thank you. So in terms of avoiding compounding stigma, we generally recommend that where it's a more generalised health service, that it's sort of proceeded with, like, we ask everyone to do this, or making it clear people don't have to answer particular questions, and a collaborative approach, ensuring that they're like asking what they're hoping to get for their appointment, and also thinking about questions about how intrusive they are, because they may seem relevant, but it's about being very, very clear about why it's relevant, and that you're not just being kind of nosy or making assumptions about people, but at the same time making it clear that you're not making assumptions, and it's important to be really clear about confidentiality, note taking, and information sharing before any dialogue, really, and finding out if there's anything that they actually need to know before you start. And then obviously there are issues around sort of service accessibility, and then the next slide, please. Yeah, and so in terms of co-production, we feel that's really essential, and I know there's been touched on the importance of being sort of like person-centered, and peer work, and seeing sex workers as experts by experience, and actually actively asking how they'd like to see change. Could you move the slide on, please? So yeah, looking very briefly at the options for co-production, recently we wanted to get a bit more information about sort of maybe through focus groups, but over the years of sort of running the service, what I've found that there's obviously, we're a small service, we have contact with maybe between sort of 55 to 90 women over a whole year, and then we may be caseworking no more than about sort of between 35 to 50 people across a year, and so the feedback we get is going to be quite limited to people with particular needs. And it is also really quite tricky often to get people together as groups. So although we do have a peer group, we have very small sort of group attendance with that. Could you move the slide on? So something we're just about to try is that we have been speaking to a small number of service users and offering them the delivery to deliver focus groups with their own peer groups in wherever they want, whether that's online with cameras on or off, in their own social setting, or like if they have friends that come around their house that are sex workers. So however they feel that they would like to do that, and this is at sort of early stages at the moment of discussion, and we're just putting an information pack together this week to distribute to those that are interested. They've seemed very keen, and the idea is to inform the service of inform the service development for our service and get some feedback and feeding back to partners, including health inequalities, and also to share this with any service users as well afterwards, so that we can look at other things moving forward. I'm going to have the next slide, please. It's the last one. So yeah, so in terms of the focus groups, we wanted to keep it, the plan is to keep it fairly fluid. So although, just for instance, in our partnership work that we do with Terence Higgins Trust, we're all wanting to see about the viability of a PrEP clinic for sex workers. What we are going to do is let them decide for themselves what they feel are priority questions, but encourage a sort of theme of like, what are your priorities, and for health, meeting your needs, and what your priorities are for the changes in services. We'll be paying people through vouchers for both facilitation and participation in the groups, and for sharing their expertise and their knowledge with us. So yeah, I'm going to end it there because we're out of time. Sorry, it's a bit of a run through.
No, that was wonderful. Thanks ever so much, Mel. I didn't want to stop the flow because we've had some fantastic stuff today, and I didn't want to lose any of that. Obviously, we'll send the slides out so people, if they have got any questions, are you happy for them to come back to you, Mel?
Yes, of course. Yeah.
Fabulous. Thanks everybody for hanging on, and like I say, awful chairing today, but I didn't want to stop people's flow because we've had some really interesting stuff and heard some interesting stuff. I know Karen has put a kind of plea in the chat, and she'll no doubt email after as well, but obviously we haven't had time to have a bit of a discussion. But if you're happy to and able to, if you could send any thoughts to Karen about whether you're interested in hearing more about what we might be able to do across the Southeast, and if you're happy to share what you are actually doing in this space, and any opportunities to do more across the region. And we've already had one suggestion about a steering group, so if people are interested in that as a way forward as well, please do get in touch with Karen, and we can follow that up and take that forward. Otherwise, we will pick up any questions that are in the chat and take those back, and share any responses that we get back on those, because I recognise that we haven't had a chance to fully explore some of those.
What I will do that. I will follow up with an email, and if we need to have an additional meeting with enthusiastic colleagues across the region, then I can set that up post this meeting. And just to say that Raven, Lucy, and I hope Mel will continue to help support us with taking this forward, because obviously we've got a lot to learn from them. But the offer is there, so. If there is interest, and also our colleagues in Yorkshire, I can see Kathy on the call. We'll be we're very grateful for the head start you've given us with the work that you've done with the scoping and with the framework. We look forward to seeing that published. But I'll be in touch post this meeting today.
Brilliant, and thanks ever so much to everybody for joining today, and I'll see you all soon.
Thank you very much to our speakers. It was marvellous. Thank you.